Right. Okay, we are recording and we are live on Facebook. Here we are.
Woohoo!
Great.
Happy Friday, everyone.
Happy Friday.
Happy National Dental Hygiene Week, everyone.
Yay.
Yep.
Yeah. It's fun to watch all the posts, all the people celebrating, and the big billboard that was done.
I know, wasn't
all
that
the lights,
awesome?
all the purple lights throughout the country. Yeah. It's come a long way.
Mm-hmm.
And it's so great right now to see that kind of community spirit in the midst of, where we could be a little mopey and we're not. And it's so great to see that spirit.
Yeah.
Love it.
We
Really,
have
really
so much to be happy for, and it's really nice to see some positive responses on Facebook or Instagram instead of there's so much negativity going on around, and we have done so much as a profession. We have pulled together, we have made it through some very challenging times, a lot of new ground, and I'm very excited to be hygiene, but I think that really this is something we should be proud of. We've done an amazing job as a profession, and we're just moving forward and helping people all the time. And I'm excited to talk to you and for you to tell us all the new stuff with oral cancer and inspire us to do it a little bit better every time. Honestly, Joe, I'm so excited that you're here with us today.
Thank you. Me too. I am in my super duper happy place, if you can't tell.
JJ, are you wearing your PJ bottoms?
No, I have my sweats on though.
Okay, good. Because I saw that one post where you were ready to do a webinar and you posted on Instagram and you had your PJ bottoms on.
The pink slippers.
Oh, your pink slippers.
Perfect.
I know. What are we going to do when we actually have to put shoes on and pants?
I don't know.
I don't think my shoes will even fit me anymore.
No.
I had to wear big girl, I call them big girl shoes. And I was like, I'm going to wear these really nice red big girl shoes. And I put them on. I'm like, oh, my feet have not been in them for a year. I was walking. I felt like I was like waddling because I'm like, I can't fall over. I got to look professional. So it wasn't a good sign, but I still love my big girl shoes, but just have not worn them in over a year.
No.
Yeah, I think it's going to force the shoe people to make some really elegant flats.
Yeah.
Yes.
And that'll be good for us all. So we're not
And wide foot.
Yeah.
I used to be narrow foot. Now I'm wide foot.
We need a double Z width.
Yeah.
We'll get a bedazzle machine and we'll start bedazzling some nice flats and make them what we want. Okay, we'll sparkle them all up, put some little rhinestones on them, and we'll make a new fashion trend. Okay, this is what we're doing.
I love it.
Sounds good.
Yeah, the evolutionary changes of the pandemic.
Yeah, no kidding.
All right. Well, we are at 12:02, so I think that we'll probably get some more people joining us. But why don't we get started? Let me just give a little bit of housekeeping, and then we'll dive right in. So those who are here with us via Zoom, you'll notice that you have a Q&A function at the bottom, and you also have a chat. So if you're looking for an answer to a question, then I might encourage you to type that into Q&A. Now we have, it's very exciting. We have a really large group today, but with that often comes lots of questions. So if we don't get to a question that you've asked, please know that that's nothing personal. It's just because of the volume of people who are joining us and the fact that we have a program to get through. So please forgive us if we don't get there, but feel free to use that for that. If you just want to say hi, we'd love to hear from you. And then I'd encourage you to use the chat for that. Okay. There will be a certificate for this course. You'll get that. We just need 2 or 3 business days to get that up and running. You'll be emailed a short quiz to fill out. After you've filled out the quiz, then your certificate will follow. All right, Kathleen, I think with that, I'm going to hand it over to you.
Thank you so much. Wow, it's so great to see everybody. And thank you so much for joining us. This is a very special week and month. We are here celebrating National Dental Hygienist Week and Oral Cancer Awareness Month and Oral Health Month. So it's a pretty special month for dental professionals. And what better way than for us to have our lovely guest, Joanne Jones, who happens to also be one of my best friends. And I'm just so happy that you're here with us, Joe. And I'm really, really appreciative of it. you know, we all know Joanne Jones, and really doesn't need an introduction. And everything that you do, Jo, you inspire all of us as dental professionals. You're such a passionate advocate to bring oral cancer awareness to not only our profession, but to the public as well. And so I'm really excited to hear your story and for you to share some of the prevention strategies that you're going to be talking with us about today. So with that, I'm going to read your bio. So JJ Jones is an award-winning speaker and recognized thought leader. Joanne has done over 1,000 presentations across the US, Canada, England, Ireland, and Bermuda. Joanne has been invited to join the 2021 Dentistry Today CE Leaders for the 11th consecutive year. In the midst of preparing to present her extensive research on HPV-related oropharyngeal cancer to her national association, Joanne's family were dealt a crushing blow of having a family member diagnosed with late-stage HPV-positive tonsillar cancer. Joanne proudly partners with the Oral Cancer Foundation in conveying the urgent need for changing the way in which we screen for oral cancer to meet the needs of today's population. And Jo, I remember when that happened. We had just started RDHU, and that was how many years ago? Like I think we had just started RDHU just before that, but that was like, you know, over 10 years ago. But many of us are aware that you're committed to elevating the awareness of oral cancer. And really, I'd love to hear, like, how did that interest start for you?
Well, first of all, thank you. As I said earlier, this is my happy place to be with 4 friends, 4 colleagues that I admire and respect so much. And also the exemplary commitment of RDHU and the RDHU to support our community. And I just want to say very quickly, throughout the last year, you have absolutely, well, you were already on the top, but you have absolutely risen above and beyond in everybody's expectations to support what we've all been through. You know, I haven't been in clinical practice, but I've been on the sidelines trying to develop educational programs, and all of you have worked tirelessly to support our community. So I just want to say a big thank you. And I'm sure I speak for everybody that is on this call. But yes, that was the situation in my own family. Actually happened in 2011 and 2012 over the course of about 16 months. But how did I get started? It probably goes back to about 4 years before that. So I would say back around maybe 2007, 2008, that I could see a trend starting to happen. And we didn't know a lot about HPV. We knew that it was very closely related to cervical cancer, but we didn't know a lot about oropharyngeal cancer and head and neck cancer. That was an emerging trend. And very, very slowly and then extremely fast, we could see this trajectory happening where all of a sudden, the other risk factors that we were so familiar with were starting to decline, the number of cases, and yet this other trajectory related to virally transmitted was going like crazy. So it really didn't take a rocket scientist. I'm not that smart. It was just easy to see that this was happening. I thought, man, this is really catching us off guard. And we are the gatekeepers of the oral cavity. We're there. So we need to get educated about it. And that's kind of how that all started, basically. Now, may I share my screen here?
Yes.
Okay, here we go. Let me just do that here and bring this up because I have a few slides here that I will share some information with you.
Perfect. Thanks, Jo. If I could start off, I do have a question for you.
Sure.
I was just wondering, just through your experience, what do you feel are the most maybe surprising facts about oral and oropharyngeal cancer that the dental hygienist should be aware of?
Okay, and great question. And I did do some preparation on these topics. Basically, the 2 major risk factors have changed the profile and the demographic of typical oral and oropharyngeal cancers in North America. So What I want to look at is making the differentiation between oral and oropharyngeal cancer. And we'll look at a little bit of the anatomy too today as well. But oral cancer is everything that is anteriorly. So smoking, alcohol, the combination of the two, and we have to talk about different tobacco forms now because there are so many different avenues in which people are using tobacco products. That actually has declined because there's a lower incidence of oral cavity cancer that we're seeing related to this reduction in smoking. But we also see this widespread, this significant rise in HPV-related oropharyngeal cancers that are affecting posteriorly. So anything distal to that V-shaped trough that is on the dorsum of the tongue called the sulcus terminalis, anything posterior to that is the oropharyngeal area, and that is the high risk anatomical area. So we're talking about tonsils, we're talking about the soft palate, all of those areas. But I think the most surprising things that is that this is, when we look at the HPV segment and we look at smoking and alcohol, they're all lifestyle factors. They're all things that we get to choose, basically. So oral and oropharyngeal cancers, for the vast majority, is something that we make a decision about. And that's really different than a number of different diseases that happen. Now, we can argue that point a little bit because diabetes and heart disease and that type of thing are the result many times of lifestyle factors, but also there's a high genetic aspect. When we look at oral and oropharyngeal cancer, we have a very small percentage that actually have that genetic tie-in. And the other thing that I think is so surprising and that our clients really, really, really need to know is that literally this is a cancer that you can give to someone else. It's not a great gift, but and I'm going to take some of the fear out of this because I know some of you may be trembling in your slippers right now with that statement. So I'm going to make sure that I take the fear out of that as we talk over the next hour. The other thing that is really surprising is that it was predicted that by 2020, the oropharyngeal site, that subset of head and neck cancers in the oropharynx, would become the most prominent HPV-related cancer site in the body. Other studies predicted by 2025, and yet it happened in 2015. So those three things, I would say, are the most major surprising factors that we need to be aware of and that we need to communicate also to our clients. And I'm going to give you some good resources as well. The biggest thing, though, that I really want to ingrain in all of your minds is that this is a virus that we can all beat. And that is so, so significant. So those kind of comprise those three major risk, or three major factors that we really need to know. I'll get that.
So, Joe, can you help me understand HPV a bit more? I feel like there's a lot more that I need to know. How common is it? How does it relate to oral and oropharyngeal cancers in general? Because you really have sparked an interest to want to know more about this.
Yeah, and another great question, and one that gets asked so often. And the first thing is we need to take the stigma off of this. We need to be able to talk about it because, well, look at the statistic here. Over 70%, this is from the Public Health Agency of Canada, and this was a 2020 quote, over 70% of sexually active Canadians will have a sexually transmitted HPV infection at some point in their lives. So that is a major call to action for us to recognize that, hey, we can talk about this. There's not a stigma around it. And yes, it is a discussion about sex. And yes, we do need to be careful. I'm just so old at this point in time that I can get away with it. But all kidding aside, you're supposed to laugh at that a little bit. Okay, thank you. That makes me feel better that you don't really feel I'm that old. But really, we need to be able to have avenues and, again, resources. We've provided you with a handout to go with today's RDH view that gives you some really good resources to be able to open up this discussion with people. So you don't have to get, kind of engrossed in a really deep or uncomfortable type of situation, but it gives us a chance to be able to at least inform, elevate awareness, empower our clients to understand that it is more lifestyle related. And the other thing too that we need to understand is 4 out of 5 new HPV mouth and throat, and there's really not something specifically called throat cancer, but that is in layman's terms, but 4 out of 5 are in males. So we'll talk a little bit more, about that as well. Why is it so much more common in males than it is in females? And actually, I should touch on that right now. When we look at the ability of a man or a woman to produce antibodies, to seroconvert. So they refer to it as seroconversion. And we're all kind of familiar with that now with all the vaccine talk around COVID. The ability to become or invoke an immune response. With females, it happens shortly after their initial sexual contact, shortly after their, first sexual activity starts. They are able to seroconvert quite early, and studies will support this and back this up. Whereas with men, it takes a number of partners before they actually have that ability to seroconvert. So that is one of the reasons. The other thing that in 2016, there always is a special topic in our Canadian cancer statistics, and HPV became so prevalent as a burden on cancers that they actually put a special topic in the Canadian cancer statistics in 2016 dedicated to this particular subject. We also saw that across the major cancer centers, Canadian centers, that it rose from 47% in 2000 to about 74% in 2012. And where this also relates to us is that an oral HPV infection is related to a good third or more of oropharyngeal cancers. And the reason I say or more is from the Office of the Chief Dental Officer, and the quote is there below. Unfortunately, good epidemiological data are lacking because HPV is not a nationally notifiable disease. It's usually asymptomatic, and the diagnostics for HPV are not publicly available or funded. So that's why, it takes a long time to get this information, and we're not getting the complete picture until several years later. And this is just a graph to see where that intersection occurred, where oropharyngeal cancer surpassed cervical cancer. This was in the US, but we mirrored the same thing in Canada. So that's basically, how common it is. Great question, Carrie. And again, the main thing is let's get the stigma off of this conversation.
Okay, so it's my turn. Can you tell us what kind of key signs we need to really be watching out for?
Yeah, there are a number of key factors, key signs and symptoms. Some of them are life-saving, not to be overly dramatic, but missing them, we can really impact not only the quality of life, but the quantity of life for clients that are sitting in our chair. As you can imagine, when it's so posterior, the visual acuity is really hindered. So it's not always really, really easy to be able to, and in fact, it's almost impossible to be able to actually see this type of cancer. I'm going to show you a picture today as well. But there are some symptoms that are readily available to us that we can use our eyes, we can listen with our ears, we have our hands, and those are the gifts that we have. Those are the senses, the capabilities with our manual dexterity. And I remember, human nature, right? Sometimes we miss all the good stuff that people have to say and the good comments, and we zoom in on the one negative comment. And I posted something. There was an article actually written for Dentistry Today, and I posted something later about it, talking about the fact that the ADA had called upon us, and now the Chief Dental Officer has called upon us as a dental community, dental professional community, to be able to integrate oropharyngeal assessment and into our screening protocol. And it was so disappointing. An actual oral pathologist weighed in and said that was ridiculous because we don't have a laryngoscope and we don't have the capability. Can you imagine? Like, what do you guys think about that? What do you think about that as dental hygienists? Are we not equipped? What do you think?
I think we are totally equipped. I mean, we see our clients ongoing and we can talk to them about their hoarseness, their change in voice. I mean, I've certainly sent people to have further investigation. This one gentleman, I've sent him twice to go back and ask again and make sure you have some more testing, because his voice is changing. He can explain that he feels something in the back of his throat. And I feel like I'm watching this thing happen, right? You know? And so I do feel that the more we have clients that continue to have good continuity of care, the more integral part we play in their overall health. And this is just one very important aspect.
Absolutely.
I had a client this week and he came in and he'd had an oral path assessment done 2 and 3 years ago. And he said it came back that it was not cancerous, but the sore has come back and it's irritated. And so we used the bell scope, we checked for everything, and we're like, you need to have this physically removed and have a biopsy done. And, you know, I feel like we don't give ourselves enough credit. We have to screen, we have to educate, and we may not be able to do the biopsy, but we can at least start that conversation and educate and inform. And really, it's so important. And it was just fitting. I'm like, guys, like, this is what we're talking about on Friday. This is why we have to have our eyes and ears and listen to all the things that our patients are telling us, because we have to be able to read between the lines. And if we see something that doesn't fit it, that doesn't seem right, just refer, discuss, bring another colleague in. Like, I went to the other op, I'm like, okay, so who's available? If there's not a doctor on the floor, I'm going to pull in another hygienist for just a second opinion, a second set of eyes on this before I, get alarming. But we really need to do more.
I totally agreed. I just saw something pop up from Colleen. And thank you so much for sharing that. And I'm so sorry for what, you've been through and what your dad is going through. But that mention of the only thing that showed up, and I haven't had a chance to read the whole message, but was that swollen lymph node. We're going to talk about that too, because that is so important, and doing a proper assessment. Let me just go back to a couple of things here. So a continuous sore throat or a persistent infection, that is really important, because a lot of times, you can be treated for antibiotics, but it never totally goes away. And often the reason it's not going away is it's of a viral origin. Pain when swallowing or difficulty swallowing. Michael Douglas had a walnut-sized tumor, the posterior base of his tongue. And of course, that wasn't something that anybody could readily see, but he had those symptoms. He had trouble swallowing. Maybe your client says to you, like Anna Louise mentioned, you notice their voice being a little bit different, or maybe your client says to you, I'm having trouble with certain dietary aspects, like things feel like they're getting caught. We need to be tuned in. And this is where our profession becomes so much more, becomes exciting, instead of just routine cleaning teeth. I don't want to get on a soapbox here, but I am so saddened when I see on some of the dental hygiene forums all the negative talk that is going on to new dental hygienists or someone contemplating getting into our profession. We need to really be proud of what we do and who we are, especially in today's world. There is an aspect of our career that, yes, becomes repetitive, but there is so much more to it. And this is one of these cases. So pain when chewing, unilateral ear pain, ringing in the ears, or trouble hearing. Those are all subtle symptoms, and they often are not going to take one of our clients to the medical doctor because they're minor. And that's where we can really play a big part here. Non-healing oral lesions, bleeding in the mouth or throat, those are a given. Hoarseness, as Anna Louise mentioned, a lump in the throat or the feeling that something is stuck, like you constantly are clearing your throat. Very, very important. Continual lymphadenopathy, any lymph node that is enlarged that lasts more than 14 days, unless you have just had, the Epstein-Barr virus or mono or immunocompromised. Sometimes those can hang around for quite a while, but that firm fixed node, persistence is key. Anything that goes beyond 2 weeks and does not resolve on its own always should be further evaluated. Unexplained weight loss, trouble breathing, speaking, trouble with articulation of certain sounds, a tongue that tracks to one side when stuck out. Again, if there is that tumor or growth that is at the posterior base of the tongue might not have free mobility. Asymmetry in the tonsillar area, a persistent neck mass despite antibiotic therapy, all so very, very important and often subtle, but all part of those symptoms. So I just wanted to show you a little bit of the HPV associated oropharyngeal sites, and you can see this kind of square here. So it's everything distal to that sulcus terminalis that I mentioned earlier on the dorsum of the tongue. And also another area that is often referred to in studies is Waldeyer's ring. And this is that tonsillar tissue area, that rich lymphatic tissue is a really big, attractive area for HPV to congregate. Now, this picture is a picture of HPV in the tonsils that was not found for about 4 months. And the patient had some subtle symptoms happening. They did notice some systemic symptoms like some loss of weight, some loss of energy, that type of issue. But more so, feeling like they were clearing their throat and some throat infections happening and pain on that one side, but it was fairly subtle. But they knew that something was happening and they became an advocate for their own health. And this was actually taken with an intraoral camera, and you can see that it's way back behind that tonsillar pillar. So I do share this full story with permission from my colleague in one of my other lectures, but I just wanted to share that with you to know that that's how far back some of these areas can be. So very, very important. So again,
Amazing.
Great question.
So Joe, as a dental hygienist, what do we need to be doing in order to be screening for these cancers effectively?
Well, there's a number of different things. So I don't want to forget and focus all on HPV because smoking and alcohol related are huge. Still a major portion of oral cancers, HPV and oral cancer, HPV and oral infection is very prominent, but HPV and oral cancer is not that prominent. In fact, in some of the studies, it says like 3%. So there are a number of things that can be done. And I'm going to share a little bit more specific about screening devices, but a couple of things. And I am showing you oroscopic loops. So I always like to reveal a professional relationship, but I am a proponent for loops in general. Magnification. So important. And I'm not going to make the leap to say that we will miss oral cancer if we don't wear loops. I'm not going to make that connection that definitive, but off the record, it's pretty well true because there are so many subtle symptoms. And especially when we look at red lesions, erythroplakic lesions have so much greater propensity to go into malignant transformation than a leukoplakic lesion. Leukoplakic are easier to see, but they don't as often end up as a malignancy. So having an opportunity to see subtle changes in color is really, really important. The other thing is a dedicated headlight. And this one is actually, and you can see the headlight source of, hey, Google, lights off. Just let me see if you can see it better. So you can see the dedicated light source there. I don't know whether you can see that well, but it is like super bright, super bright in the oral cavity. Hey, Google, lights on.
So techie you are.
I know, but it's my son, not me. Remember, I'm
so impressed.
I have younger kids. So the headlight these are really important to have a dedicated light source, because how many times, you can all attest to this, has your head been in front of that overhead light source as you're doing one of those extremely bizarre positional things that's going to cripple you for the rest of your life, to be able to see in that dark little man, or not man cave, but that dark little called the oral, excuse me, I got excited about that, called the oral cavity. You know, it's hard to see. So having a dedicated light source is really, really important. Any other thoughts from you as well on things that are helpful to you?
Well, I think the intraoral camera is a key factor. I mean, we can explain and use all the words we learned in school, but to have a picture and freeze that moment in time and then have them come back in 2 weeks, and is it gone? Is it better? Has it changed? And there's no fooling it. You can put those two pictures up side by side, and you can even send a picture home with somebody and say, you know, monitor this. And, you know, because they're now dreaming about it too, because now you've pulled their attention to it. And some of them, if they can access it, they love to have that picture at home. So it's not playing tricks on their mind that, yes, it is healing, you know. So I think the intraoral camera is another tool that is like an essential thing to use as much as possible. And one of the things I talk about in my mastery program is, you know, use that perio probe, get that probe in there. So you've got it recorded with the probe right beside it. You get those measurements, and, you know, and I've sent pictures off with the probe on extraorally to dermatologists, and my client came back and said, well, my dermatologist wondered what that was. And I told them, you don't have a good hygienist if you don't know what that is. Oh my gosh, I thought, oh my goodness, he needs to then pay more attention to what's happening during his appointment. But it's good for us to get all of that information in one picture, right? You know, give them some orientation on size and get those vivid colors that we can get with our intraoral camera to record.
So important. And you're getting that magnification at the same time.
Yes.
Yeah. Great. Great. Any other thoughts?
I love using the screening devices, whichever you have in your operatory. There's lots of different choices out there, but it just gives me that additional tool. And just like Anna Louise, I love to take probes and measure those things and keep track, because then also when I'm going back, I can see the borders. I have a better idea of where I'm looking at. It helps me ground for those images. So
yes,
setting them with the patient so then they can actually evaluate it and measure it and see it, it makes a big difference.
Yeah.
Joe, what about the throat scope?
I have to hold myself back because I'm going to talk about that, and I'm going to give all your listeners a tool and an app. You're talking about measuring and taking really good intraoral pictures. I have something very exciting to share. So just hang on though.
All right.
I'm going to go back here. Let me go back. Okay. So let me just go ahead. Just a sec. I just have a couple of pictures I wanted to show you. So just on that whole topic there. So the ADA expanded their policy on oral cancer detection to include oropharyngeal cancer. So this is what I was talking about earlier. This happened October 2019. And then we got the call to action from the Office of the Chief Dental Officer just a few months ago, actually late 2020. So a couple of things I wanted to bring out to you though, or bring to your attention, is oroscopic with their headlight. You might not think this is that important, but this color rendering index, 90 is the closest to what natural sunlight. We've been living in this world for years and years and years in a 70. You can see the difference here. And that's where those subtle changes with an erythroplakic lesion makes such a difference to be able to evaluate that. I'm not talking about diagnosis, but to assess and evaluate makes such a difference. The other thing, and I think I have this here, yes, I do, the Pro gears. So this got nice, comfortable band on the back. But what I really like about this is it's got the capability with the distance here to wear your loops and also for your headlight to be accommodated here in the face shield. And that's super important, because why should we forsake best practices because we have to have all this other PPE on. And then one other thing I was going to bring to your attention, and this is in your handout, is there is a video that goes through the screening examination that is on Dental Hygiene Canada. So the link is in your resources for you as well. So that's it. Yeah. And I can't remember what the next.
I'd like to add to that, because I see a lot of people asking for the handout. So if you weren't on the RDHU email, like if you just went on to Zoom direct on your own and not through RDHU, then we'll send you the handout if you didn't get it, because it went to everybody yesterday. But we'll also attach it when we upload it into our portal. We'll have it there as well. So they can watch the recorded, you can do your quiz, get your certificate, and then you'll also get your handout.
Perfect.
And Kath, if anybody does need, I should just send it to you anyways. I can send my slide deck in a PDF because I didn't.
Oh, people would love that.
And now I've said it, now I'm done, right?
You're committed.
I have to do it. Okay, you have my word.
All right. Well, you just made a lot of people happy.
My word is my bond. Isn't that Peter Pan?
Yeah. So very good.
Thanks, Joe. Yeah, there was a couple of requests, so that's that is definitely going to make people very, very happy.
Right. Yes, Christine, it is coming. So I'm going to make a note of it too. I'll make sure I do it right afterwards.
Make sure you share this with your friends, because I think everybody's going to want this slide deck. But you've got to watch it to get the slide deck, okay? That's how we've got to make sure it happens. You got to get the slide deck.
Marketing 101.
Got to throw it out there once in a while, okay? Got to throw it out there.
Joe, I was wondering if you could tell me if there is a specific test for HPV.
Well, that's another great question. These are all great questions.
Thanks.
You're welcome, Kathleen. For women, yes, we have the Pap test, and that is the most reliable test we have. For men, there is no reliable test. I'm going to use the word reliable. There are tests out there, but there is no reliable test at this point, and any study will support that statement. The sensitivity specificity is just not high enough. There was an article that was written in the Journal of the American Dental Association. It said more tests, more questions, and the level of anxiety is going to be increased so much. And let me just share my screen for you, because I did have a slide on this. Sorry to be going back and forth, but
no, it's good, Joe.
Beautiful faces as well. And I don't want to just see my information here. So the whole reason for not doing, like Oral DNA, great company, does HPV testing. However, what are we going to do with that information when we have it? I'm sorry, but I'm just being practical, because about 80% of the population have HPV exposure. 7% of the US population, and it's the same in Canada, have an active oral HPV infection at any given time. 99% clear the infection. So what are we going to do with these people that we're telling them that, oh, you have an oral HPV infection that is in your mouth? What are we going to do with that information? Now, if it's a persistent, this is where we get the malignant transformation. For that smaller number, it's a persistent infection with a high risk strain that doesn't clear. So somebody like that, I'm not saying that oral testing doesn't work or shouldn't be used, but more in a high risk population, or somebody that has a persistent oral HPV infection, because these tests will tell what strain. So they're going to say, okay, this is a high risk strain or this is a low risk strain. And if it's a high risk strain, then there is more in the regard to referral management, which I cover in my RDHU courses on HPV and implications for dentistry. There's more to do with the referral management strategy for someone with a high risk than someone with a low risk. So good question, but yeah, basically there's not a lot at this point in time. A lot of unknowns.
So what are your thoughts on adjunctive therapy and adjunctive testing and things like that? I know you kind of, started to give a little bit of a shout out, and I can see the excitement, and I know how important it is, but, do they really work? Because that's always a question. People say, do they actually work? Can it make a big difference to my practice? And what about false positives?
Yeah, a good question. I do love talking about this. And again, I have a professional relationship upon my own request to the company years ago when I looked at the scientific platform, and that is BellScope. There are other adjunctive screening devices, and at the end of the day, I'm just glad if somebody is using something. The majority of the studies have been done solely with BellScope. They have been the leader. They do have the market share in adjunctive screening devices. The biggest misunderstanding is that they're screening devices. And a lot of times people say, I want to look at it with BellScope because I want to know, should I refer this? No, you know what? If it persists more than 14 days, it's referred. BellScope is not going to tell you or convey a diagnosis. So that's where this whole understanding about false positives, it's really just a misunderstanding of the positioning of the device and its capabilities. So it's another set of eyes. Because the sad truth is over 70% of oral cancers, and that's where BellScope really shines, and excuse the pun, but that's where it really shines, is to have a capability to be able to assess down to the basement membrane where cell differentiation starts. So, you know what I'd like to do? I'd like to show you, it's a very short video. It's about a 2-minute video, and it's so well done. And it kind of shows the difference between what you see with your own eyes and what BellScope would actually show you. So let me just go to that and move forward here. So that this is a diagram, and this will be in your handout as well. This shows that, you know, where we don't want to discover oral cancer is invasive squamous cell carcinoma. We want to be back here at the basement membrane, and we can't do that with our own eyes. We're not capable. So let's have a look at this video. So let me just go ahead here for a second. And I just wanted to make one other mention here. So I love technology, as we all do. So here is BellScope. So again, a safe blue light that is shone into the oral cavity. And I obviously can't do the examination here. But the newer generations of BellScope, you don't have to have the lights dimmed. You don't have to be in a dark room. It does give you more of a contrast. So if you can darken your room, that's great, but it's not a necessity. It's handheld, it's portable. But what I really love, and I know that I'm speaking to the converted at this point in time, is the technology that is capable to us. So this is an app. So this is the BellScope app, and you're able to capture images, and you're able to, let's just look at an image here. You're able to actually, let me just go back for a minute here. Let's go back to review images. So you're able to capture an image and then you're able to email it. So what you were talking about earlier, Anna Louise, of capturing something, I mean, what if we did find something? And 2 weeks later, we did check, and that dark demarcated, and this isn't a Bellscope course, but there's a great link for you to all kinds of Bellscope instructional videos. But what if we did find something, we referred it off? Wouldn't it be great to be able to send the image that we see, because the oral pathologists do understand this, of course, and be able to show what we have actually seen. So my feeling on it, you know, last time I had a mammogram, last time I had my eyes checked, they said, oh, we've got an adjunctive or an additional test. And these are the benefits. This is what it will actually do for you. Would you like to have this exam? And in one case, there was an additional fee. In another case, there wasn't. Who in their right mind is going to say, no, don't worry about that. Like, I'd rather have the minimal amount of care. I don't want to have the best. Like, let's leave early detection of cancer. Let's leave it to chance. Okay. I like taking a risk. No, we're not going to say that. So important to recognize the value of these adjunctive screening devices and be able to really see things that we couldn't normally see. So anyway, that's it. That's my feeling. So yes, yes, and yes.
I know I found it to be such a great tool to add in for conversation, for just showing how we go the step further. And I think now more than ever, coming back into the environment with COVID all around us, people want to know that you're screening. People want to know that you're trying to find things and be proactive as much as possible, because it's about risk assessment and people are very open to this. It's like, let me just see. It doesn't mean that it's not going to happen, but let me just see if there's a risk here. And if there's a risk, let's talk about it. Let's figure it out and let's manage it from here. Okay.
Good point. Yeah, very much so. I think people are open to so many different things today, and we have so many opportunities. So is that a family member or a dog coming in to see you? Aw. Don't you just love Zoom nowadays?
Yeah, exactly. Right. They capture life as it happens.
Life as it is. Exactly.
Yeah.
Very important. Learning from home. And so he has to get some coloring stuff so we can do art class. So bonus.
Exactly. Go mom. What were we going to say, Anna Louise?
I was just wondering if as the next step, can you talk to us about like the vaccine and how we should talk about it and how it relates to the oropharyngeal cancer and you know, what is Canada doing about it?
Yeah, I would love to. And actually, I was reviewing a couple of weeks ago what I presented last year on oral cancer and oropharyngeal cancer. And the data that has come out is like so exciting to be able to see some of the information that we now have that we can share with our clients. So this came from the CDC, the Centers for Disease Control. HPV vaccination can prevent about 92% of HPV attributable cancers in the future. Now, I read Maura Gillison. She is kind of the guru of oropharyngeal cancer, HPV related, just a brilliant woman, researcher, scientist, clinician, and anything that she publishes is so worthy of reading and so worthy of our attention. But she had made a prediction a few years back that by the time the vaccine is actually kicked in, that we are going to see oropharyngeal cancers drop by 2060. Now that was said a number of years ago, and I believe, I'm taking a leap here, but I believe we've made more significant inroads than what was originally predicted. And I think we're going to see that turnaround faster. However, it's not going to be overnight, because don't forget, we have had the vaccine for young women and females at a very young age, but the inclusion for males wasn't until more recently. So when we look at the vaccine protocols, in June 2020, Gardasil 9 was approved in the US for prevention of oropharyngeal cancer. So it is approved for anal cancer, penile cancer, vulvar cancer, vaginal cancer, cervical cancer for sure, but it has not been approved yet in Canada for prevention of oropharyngeal cancer. And you may ask why. It is coming. It will happen. However, it takes time to assimilate all the data and be able to have the information to be able to make that decision. And one of those decision makers is, this was an interesting study that is undergoing right now. The actual study start date, as you can see on your screen, is February 27th, 2020. And the estimated completion date is July 15th, 2024. So the quote at the bottom, similar to what is being demonstrated for HPV-related anogenital infection and disease, if oral persistent infection is prevented via HPV vaccination, then it can be inferred that head and neck cancer caused by the 7 high-risk HPV types in the 9-valent, so that's the Gardasil 9 HPV vaccine, can also be prevented. So this is the kind of data that they are waiting for and they're collecting for Canada to be able to say, yes, we are on board. So again, I see it happening. Some of the other things that are wonderful statistics, and this came out of the BC school immunization program, and this was a 12-year school-based immunization program, that they found it dramatically reduced the appearance of precancers with cervical screening of young women, 60% less likely to have precancerous cells upon examination later on in their age group in their 20s. So there were 35,000 BC women enrolled in this study. So that was a great result. So these are all great results that we have that are going to start to drive this indication. This shows HPV infections targeted by the vaccine have decreased since vaccination was introduced, 88% in teen girls and 81% drop. These are hugely significant. And this is something that I wanted to share with you because I believe a question was asked about, as you get older, and the vaccine is indicated for females. Actually, there is by NACI, NACI, which we're really familiar with at this point in time with the COVID vaccine. There is no upper age limit. So in essence, an OBGYN could prescribe Gardasil 9 for an older female if they felt they were at risk. This was really interesting. The efficacy of the Gardasil vaccine to reduce recurrence in adult females with previous disease. The HPV vaccine reduces the recurrence of abnormal PAPs 70 to 80%. Again, hugely clinically significant. And the HPV vaccination reduces the recurrence of genital warts. So that's more your HPV 6 and 11, not as high risk, but transmissible as far as disease capability to another. 75% reduction. So this is really interesting. And these are women that had cervical intraepithelial cancer. And this has reduced their capability of recurrence because that immunogenicity, and I'm just going to stop sharing here, big word for the ability to invoke an immune response, is sometimes not throughout a lifetime. As you get older, your immune system may become compromised, or there might be other factors. You've got another disease process happening in your body that's not going to enable you to fight the infection. So that is new news, new understanding, and really clinically significant.
Well, thanks, Joe.
Thanks, Joe.
You're very welcome.
So what can we do as dental hygienists to elevate awareness?
Okay, so all of you need some tangible resources, right? Like, how are you going to go in and say, okay, the greatest risk for transmission of this disease is oral sex? How are we going to approach this? It's a little awkward, to say the least. So you need some help. So I'm going to be your helper. Just a second here. I'm just going to show you a couple of things that I have included. This you have in your handout. This is one of your handouts from the Chief Dental Officer of Canada. great article, and you may want to keep it on file. This I'm very, very proud of. We just created this with the BC Dental Hygiene Association, and they have graciously and generously shared it with everybody. This is a poster on the left-hand side, and then there's a handout. And the handout is what you need to know about HPV, but the flip side is about the science. So all of these conversation starters on the far right are supported by the science. So I really, really like the way BCDHA has developed that. These are from the CDHA, again, some great resources and all free downloads. So awesome, awesome, awesome. And there's a whole list of things. So that's not just it. There's all kinds of things that I put in your other handout, which will come with the slide deck too. I haven't forgotten.
No, I just have, I have one final question for myself anyways. And that is just, in our COVID world, how would you suggest that we better communicate the importance of early discovery of oral cancers?
Okay, well, in our COVID world, it has been challenging to be distant from our clients. So there are a couple things I want to bring to your attention. A global campaign, well, hugely North American campaign, but it has gone global, is checkyourmouth.org. And that is actually in your handout as well. And checkyourmouth.org was a collaboration and a pleasure to be able to introduce this company, which some of you may have heard of, ThroatScope, which is an illuminated tongue depressor, with the Oral Cancer Foundation. And we created a video and taught people basically how to do a self-examination between professional visits. So it takes nothing away from what we can do as a professional, but it adds the importance of, hey, oral cancer, just like periodontal disease, is painless often until it's in the later stages. So that, I'm really proud of that collaboration and happy to have you share that. And there's a lot of information in your handouts about that. The other thing that I wanted to talk to you about as well, I've got so many things on my desk here, is the TelScope app. And let me just put this in here. So on the back of my phone, you can see I've got this little clip, and I always do this, go the wrong way. Jones law of twos. If there's two ways to do things, I do it the wrong way, the first way. It's an interesting way to live. So what happens with this? This fits on the back of your phone, and this goes in here. So, hey, Google, lights off. So if I put this in my mouth, you can see how it lights it up, but I can also retract as well. So that's very exciting. You know, I can retract, I can do all of these things, but it gets better. Let me just go in here for a second. If we go to the TelScope app, so this is TelScope. This is an app. So if you go to the App Store, TelScope, so you've got a VelScope app, which was for the adjunctive screening device, and you've got a TelScope app. So this is for telehealth. And this gives you some information, but what you're able to do is capture an image. And I don't have somebody with me to be able to demonstrate this to you, but you can capture an image, but you can not only capture an image, you can also annotate as well. So that's what I love. Hey, Google, lights on. What you can do is you have a capability to be able to circle the area. So if your client is at home and they're concerned about something, they circle the area and they say, hey, I'm concerned about this. Or you as a clinician can take with a dedicated iPod Touch or a dedicated iPhone in the practice, can take high-res pictures and be able to send these off as well to the oral pathologist. So it's only limited by your creativity. It's an awesome, awesome capability. Let me just go back here for a second, because I had a couple of other things here I think I wanted to share as well. So that's Check Your Mouth, and the OCF store has a lot of different things that you can use for Oral Cancer Awareness Month. There's the a shot from the self-examination. There's the TelScope telehealth system, and the information is in your handout for that. And then I also wanted to say that RDHU has some great courses, goal layering activities for you that are so reasonably priced as well. And there's a a 3-part series, and there's an oral cancer bundle. That's all in your handout as well. And a breaking news alert. With permission from RDHU, I can share this. I'm so excited that when we get a little bit past our COVID world, I am in the midst of developing a really truly experiential workshop where we can gather all of these different devices. You know, we'll have everything in there and be able to partner up, be able to learn the theory, and then partner up and be able to perform the extraoral, intraoral examination, and be able to, with Apple Play, be able to do actual live examinations and be able to interpret the results as well. So really, really excited to do that. And I offered that to RDHU because I couldn't think of a better facility to be able to offer that to because of what you do. And I am going to shut myself down at this point because I feel that's most important, because I know we have a whole bunch of questions and I'm willing to stay on. Everybody else can do what they want. It could just be me without anybody from the panel of the RDH view, because they're thinking, does she ever stop talking?
I want to know the answers, so I'm staying. And then you have a movie you want to end with too. Do you want to do questions and then, or do you want to end? Yeah, do you want to end with a movie, and whoever wants to stay on can stay on. We can also increase the certificate, I'm just saying, by 1.25 if we're staying on for. Just so everybody knows that, you know, and this is recorded as well. So if you have to leave, you can always come back.
Okay. I just don't want to take anybody's time disrespectfully.
I think everyone's quite happy to keep learning.
Yeah. Yes, exactly.
Oh, do you want me to show the video?
Yeah.
Sure. Yeah. There was
and then we'll kind of conclude, but then so you finish your presentation and then we'll ask the questions. And if people want to stay on, they can stay on. If not.
Okay. This video is a tearjerker, but I personally love it. I think it really speaks to us as a profession. It's not talking to dental hygienists, but I really feel it speaks to us. So I hope you enjoy. That's not it.
When we're laying on our deathbed, you're not going to worry about how much money you had, how much power you had, how much prestige. You're going to see that that was all game, that was all an illusion. The only thing that's going to matter is the impact you had on other people's lives.
We are all on a separate journey. But the beautiful thing about our life here on this earth is at my funeral, they ain't going to talk about my success. They're going to talk about who Nick was and how Nick lived and how Nick loved and encouraged.
Success is incredibly important, but even more important than success, it's having an impact. It's knowing you haven't walked the planet in vain. It's knowing that because you've been here, you've blessed lives, you've developed people, and you have made the world a better place.
The effect you have on others is the most valuable currency there is. Everything you gain in life will rot and fall apart, and all that will be left of you is what was in your heart.
Life is a mirror, and life gives us not what we want. Life gives us who we are. When you were born, you cried while the world rejoiced. Live your life in such a way that when you die, the world cries while you rejoice.
Wow, Joe, that's amazing. Thank you.
Okay, I'm ready to
Goosebumps.
cry.
I
But
am.
the reason I put that in there was screen each and every patient, client. If it persists, refer, but above all, make an impact. Like, we have such a capability to make an impact. It's unbelievable. Anyway, happy National Dental Hygiene Week. You all rock.
Yeah.
And we all make an impact by even just attending this seminar or this course, listening to us. We're making change. We're bettering ourselves, which ultimately betters our patients and our clients. So, you know, that video gave me goosebumps, and you know, that's what we're all here for today. That's why we're here on Friday Fun Day. We're, you know, trying to inspire you to make a difference. So thank you, Joe, for sharing that wonderful video and for all of the knowledge and resources. We really can't thank you enough, honestly.
It's amazing.
And I just wanted to say, if anybody, I know there's a couple of questions about the name of the video. I think it's called Make an Impact. However, my email address is on that handout. So email me if there, you know, if there's anything that you don't get answered or you want to have a conversation about something, please don't hesitate.
So let's look at some of those questions that have come in, Joe, if that's okay.
Yes, for sure.
One of the questions actually was quite interesting and something I hadn't really thought of, but do you need an HPV vaccination if you are a virgin or not sexually active for years?
That is a good question. And there is so much new research coming out. I'm just actually developing a course on risk prevention strategies. And there is a Finnish family study that actually shows transmission in the birth canal, which is amazing. So there were like 33% of the children born to mothers that had the active infection were actually infected with HPV. Now, their immune system kicked in and they monitored them all the way along. But there also is a lot of discussion about open mouth kissing, French kissing, whatever you want to call it, that it can actually be transmitted between the two. That's not the most common and prevalent route by any means. But the whole idea of vaccination of young girls, young boys, is before they become sexually active. Think of putting a bicycle helmet on. You want to put that on before you get on the bike, you know, not after and fall and bang your head and have a concussion, go, oh yeah, okay, I'll put my bike on or my helmet on. You probably would say I'll put my bike on at that point because you've knocked your head so hard. But it's important to be proactive. Now, let me take that question one step further. Say you've been in a monogamous relationship and all of a sudden you become single for whatever reason, whatever life has thrown at you, and you all of a sudden have a new partner in life that has had exposure to other partners. A lot of OBGYNs really, really endorse, because of those statistics that we saw, that the immunogenicity is not going to sometimes last forever because of other factors. So it's not against protocol to actually vaccine again if there is going to be exposure.
So you do it again.
I guess, you know, if you were going into the monastery or the nunnery and we're not going to be engaging in, it's not really funny, but if you were not going to be engaging in any sexual activity, then your opportunity to actually be in contact with the virus would be severely diminished.
There was another question that came in. So do you know, would there be more than one of these symptoms? So basically, if they have one symptom, would you refer, or would they want to have multiple symptoms before you refer for a biopsy or a second or another look?
Okay, good question. Well, say somebody had ringing in their ears. We probably at that point would ask them if they have been referred to an ENT. But if there were no other symptoms along with it, that would be, I would say, one of the, not that it would be a minor symptom, but it normally would go along with something else because there would be encroachment on a nerve. So there would probably be another one in that list that you could correlate together. So that list is so important to have so that you can ask those questions and you can have that capability to be able to extrapolate that information. And then once you get, say they say, well, I'm having trouble swallowing, or I feel like I'm continually clearing my throat and I've been treated for gastroesophageal reflux disorder and it's not treating the symptom, I've still got that, then that is something that should immediately tweak a thought in our mind that this needs further evaluation.
So there was a couple of questions actually that came in regarding billing for this service. Do you know, I'm not any particular province, but do you know in Canada if there is a way to bill for oral cancer screenings?
For adjunctive screening devices, there are in some provinces. I believe there are 5 provinces that have a code for it. Please don't quote me, but I think it's 04430 if I'm not mistaken. Don't quote me. Don't say Joanne said that's not true. I can't find that. It's something like that. But there is a code for adjunctive screening devices. The ODA has not incorporated it into their fee guide. I do know that. A lot of practices will provide it free of charge because they know it's a practice builder too. And more so important than that is the fact that they're offering the best standard of care. So that's the reassurance at that point in time. But, you know, as Kathleen, I think, was mentioning in the last view we did about a year ago, that people were talking about in a group about going to their dental office and the dental hygienist used Velscope. Turned out it was Velscope because of the way they described it and how great that was. And they really felt it was leading edge. And that is so important that we have that positioning and that posturing, especially in a very competitive world and in a fearful world. I think, Carrie, you were mentioning about risk assessment and how important that is. So some practices will charge for it, but many will not. It pays for itself, believe me.
And it's one of those things that this is in our area. We own this area. So we're not going to get this done by going to our GP, right? So, you know, this is something that we really need to implement. And then, you know, if it isn't covered, right? Well, at least, like you say, you can use it as a marketing tool. You can use it as a state-of-the-art facility or office and all that. But yeah, it's a shame that it often comes down to the bottom line, right?
Exactly. Unfortunately. And we're all well aware of that this past year.
Well, that was fabulous. Is there anything else, ladies?
Was a couple that came on, it was earlier on. So forgive me if you already covered this, Joe. I was
no problem
answering a couple of them. So when you were talking about, I think this is when it came up, when you were talking about older ladies having the vaccine, someone asked if that means they should be getting it multiple times.
There is a booster for those that have had Gardasil 4. There is a booster. Many of us, when we say older ladies, many of us in an older age group or that chronologically enriched age group have not had a vaccine at all because the school immunization program has not been around for decades and decades and decades. So I believe the vaccine came out in about 2008. But the actual integration of males and females came out much later. And the Gardasil 9 was in the developmental stages for many, many years. As I think I might have mentioned, the HPV vaccine took 27 years to develop. So it took a long, long time of exhaustive clinical trials before it was actually released. So when we, you know, compare that to the world we live in today, it's a very different picture because of the urgency of where we're at. But again, it's an introspective question. You've got to really look internally into your lifestyle behaviors to be able to say whether or not you would be a good candidate or should be getting the vaccination.
Okay, perfect. And I don't want to speak for you, but there was a couple of questions. The recommended age, I believe one of your slides said 11 or 12. Is that the age?
That's correct. The studies have been done from 9 to 26, and then some additional studies were done up until the age of 45. but the school immunization program is age 11 or 12.
Perfect. Perfect.
The bicycle helmet program, I call it.
That makes sense.
Okay, great. I think everything else, like if they're asking for some of the devices that you showed, I believe in your handout, there's links to
Yes, to everything.
every device you showed.
Yes, correct.
There was a couple that came through the chat, so please forgive me if I've missed your question. It's
No
just a little bit.
problem. Please don't worry. It's better to answer it twice because I might answer it a little bit differently or somebody might get something more out of it. Not a problem at all.
For sure. But for anybody whose question I just missed, I do apologize because if it's placed in the chat, it's a little trickier to go back and make sure I didn't miss. Okay, one more that I know I missed. My MD stressed the importance of testing for HPV at a PAP, and they had to pay $110 and the results came back negative. Does this mean that I do not have to worry about my oral cavity as well?
Well, first of all, that's a snapshot in time. So, and I don't mean to be negative or frightening, but there's so many things we don't know specifically, but that test that day is a snapshot in time. That doesn't mean that at another time it might be negative. It also, I want you to please remember that 99% of people with a functioning immune system will clear that virus. And it might take 3 months, it might take 12 months, it might take up to 2 years before you actually clear that virus. Now, normally what they do, and again, I can't speak to all provinces because I don't believe that this is federal legislation, is that a PAP test is done if abnormal cells are detected, then they look for HPV specifically. So often to recommend an HPV test, because the majority of us clear it, it really depends on the individual thought process of the medical professional, in my humble opinion. Now, mucosa to mucosa can be transmitted. When we look at HPV itself, there are some studies say over 100, some say over 150. The Oral Cancer Foundation says, that's my reliable source, will say over 200 strains. The majority of these do not have the ability to transform into cancer. And some of them are skin warts. Now, skin warts can happen by self-inoculation. That's skin to skin. What we're talking about today is sexually transmitted. So it is mucosa to mucosa. The chance of having it in dual sites is not particularly common. It's not to say that it doesn't happen. It can be transferred. Use your imagination and creative thinking, but I want to bring you all back in so I don't lose you to other thoughts that you may be having. But you can imagine the different sites through mucosal transmission. I actually, at a Yankee meeting one time, I had Barbie dolls with me.
Of course you did.
Somebody in the audience did ask, I don't understand why, if cervical cancer is being diminished by the vaccine, why we're seeing less, or why we may see less oropharyngeal cancer in males. So I realized after that, I needed to have a visual. I needed to have those Barbie dolls.
That would have been a fun session.
It was interesting. It was memorable. Let me put it that
way. That's good.
I hope I answered that question.
Yes.
So yes and no. You know, there is a chance, but it doesn't necessarily. I remember watching something on YouTube by Maura Gillison. She said, this virus is so different than other viruses, where it doesn't travel through the whole body and manifest itself everywhere. It has to be mucosa to mucosa.
Yes. Well, Joe, I want to say thank you so much for the extended time. For everyone that has stayed on, yes, we want to make sure that we want to, remind us to try to take your selfie with purple, post it on social media, share the positives that we do, because we really make a huge difference. We do have a giveaway from RDHU for all that have stayed on. We would like to thank you guys for really acknowledge all that dental hygienists do out there. We are change makers. We do so much for the profession. So we would like to give away a beanie.
Yay!
So To win the beanie, if anyone, let us know. I am trying to watch Facebook, social media, as well as the Zoom. But if your birthday is today, put it in the chat. If it is your birthday today, you can win one of these. So let's see if anyone has a birthday today. I know Facebook Live's a few seconds late, so we're just sort of watching to see. Let's see here. All right. Doesn't look like anybody has a birthday today. So if your birthday is close to today, let's say it was yesterday or 2 days before or 2 days coming, let us know and you can win yourself a beanie.
Is it the way we're wearing them, maybe, Carrie?
I know, nobody wants to.
You guys look gorgeous.
There we go.
New beanies. Yeah, they look great.
Tomorrow. Pamela has one tomorrow. So it looks like right now, Pamela, April the 13th, very close. So tomorrow's right now. Excellent.
And Celeste? What's tomorrow? Yeah, tomorrow's the 10th.
Yeah, tomorrow's the 10th.
Tomorrow's the 10th.
Celeste is 2 days later. So Pamela, it looks like you have won yourself a beanie. Yay! So if you want to email
info,
thank you,
at rdhu.ca.
Let them know that you won the beanie from the RDH View today, and we will look after getting it to you. So Kath, do you want to just let the members know and people watching some of the upcoming stuff we have going on at RDHU?
Yeah, there's so many. There's so many things coming up. So just one that I wanted to talk about is yours, Easy Steps to Integrating the AAP Classification into Your Practice. That's coming up April 19th?
Yes, I just had to check my calendar. It's a Monday night, 2 Monday nights in a row, 2 hours each night. And it's a new one, so it's going to be different than what I've done before. And we'll be expanding on some different parts, oral systemics, mucogingival stuff, and, just kind of breaking it down a bit further.
And we have our quality assurance one for our Ontario people. Carrie, I could go on and on. There's so many. There's brain health and the role of the dental hygienist with Anne Rice.
Yeah.
That's in May. We've got Anna Louise. Anna Louise, you have your essentials for documentation, your mastery of skills. Oh my gosh. We have mysteries of myofunctional therapy coming. Again, Joe with Joe Siegfried.
What's our next view about?
We have Dr. Viviano. Oh, yes, I have to share this. And I haven't sent the email, the tracking. I've been having computer issues. So that's going out today. But we're doing, for Oral Health Month, we're doing a convert manual to power. And that's all for this month. So for every client you convert from manual to power, you can track it on the sheet. Then we're picking 5 winners to get the IO. And we're going to announce it on the next RDH View with Dr. Viviano and Elaine. Elaine, I can't pronounce her last name.
Steckel,
yes. So they are going to be our guests, and we're talking about sleep apnea. They're from Sleep Disorders Dentistry.
Mm-hmm. It's going to be a good one, too.
And that's May 7th, Friday, May 7th. Is there anything else that I'm missing? There's just so many things. Ultrasonics with Danny. We've got social justice and improving access to oral health care with a new presenter, Dr. Sanj Mohanta, and she's also doing medically compromised, dental management of the medically compromised client, cannabis awareness for the dental professional with Stacy Bobak. So yeah, there's just so many different courses coming up. But if you go to RDHU, you can click on, live streaming, and you'll see all of the different ones we have. But we've also created the bundles so that if you are practicing in a province where you have to maintain a learning portfolio, you can just go onto the bundle. Like for instance, we have the oral cancer bundle. With Joanne Jones, you could go on there and everything is there. So it's like one goal. It's like a goal in a box, that's what it's really there to help you with as well. And then you can add today as your extra layering of learning as well.
Exactly.
And then all the extra other resources. Joe, that was fabulous. When I saw your handout and your resource page, it was like set. It's wonderful.
Did you know
And
we
it-
had a lovely young lady from New Zealand on with us this morning?
Oh, nice.
21 a.m. So shout out to Christine for getting up so early.
Oh, very nice.
Oh.
Wow.
From New Zealand. That's amazing.
Yeah, I
Thank
love
you. It's amazing. All right, you beautiful souls. We'll see you, Carrie, I'll see you in half an hour.
Yep.
Everybody else, have a great weekend and keep celebrating.
Yes, sounds good. Bye, everyone.
Bye.
Bye.
There.
Thanks, Joe.
Thank you. Pleasure.